Management. Clip or coil, once you identify the aneurysm. Hydrocephalus is a possibility. And by this, you're going to then drain out the fluid, interventricular catheter. However, as soon as that happens, you're always worried about what, please? Infections. Vasospasms, you want to treat that. Highest rate within 21 days. Treat with nimodipine, calcium channel blocker. Always look for or try to manage your hypertension, maybe hypervolemia, hemodilution. And here, once again, you want to try to control things and manage. And so therefore, interventricular catheter. Oftentimes, you'll find vasospasms within 3 weeks. Continuing our discussion of subarachnoid hemorrhage, let's officially enter the topic itself. We just came off our discussion of aneurysms, and if that aneurysm is to then get large enough, it ruptures. In this case, with the baryaneurysm that we refer to, you are then going to bleed into your subarachnoid space, and perhaps even then bleed onto your interparenchymal type of hemorrhage. The complications here, as you know, would be the worst headache that he or she has experienced, called quote-unquote thunderclap headache, meningismus type of symptoms, and altered mental status. On CT, you can then expect to see the interparenchymal type of hemorrhage that you see here. The complications that you're worried about, as we had mentioned earlier, if you peak approximately 3 weeks or 21 days into your subarachnoid hemorrhage, you want to try to manage your vasospasms, and there we refer to our calcium channel blocker, nimodipine. Or you are now also having issues with properly draining your cerebrospinal fluid, resulting in hydrocephalus, and that increased intracranial pressure could be then managed with a drainage, maybe perhaps with interventricular type of catheter. Summary: risk factors: age, female gender, African American race, most likely due to hypertension, smoking, stimulants, alcohol. Preventive medicine. Remember, if your patient you know is predisposed to developing an aneurysm, usually about the, let's say, 5th decade of life, management of unruptured aneurysm, 1% of general population. Annual risk of SAH is 1 to 2% is related to aneurysm size. Signs and symptoms, we talked about the headache. It could be loss of consciousness. Think of it as being like a space-occupying lesion. Differential diagnosis. At some point, we have discussed cluster headaches, migraines, and meningitis are all differential diagnosis when you're dealing with subarachnoid hemorrhage. Acute and post-acute diagnostic workup, CT scan. We did a lumbar puncture. We discussed our the tubes that you would find, for example, because you're continuously introducing blood into subarachnoid space. No matter how many samples you take for RBC count, it'll always be pretty much elevated between 1 and 4. Angiogram, you want to check out what caused the subarachnoid hemorrhage. And transcranial Dopplers as well could help you. In other words, ultrasound. The management here will be clipping, if we're talking about coiling of an aneurysm, treatment of the vasospasms that we talked about, nimodipine, and we have our therapy of HHH, hypertension, hypervolemia, hemodilution, HHH therapy, all so that you can manage your subarachnoid hemorrhage.